Hello, I'm Michael Tam, a part-time Sydney GP and academic at the University of New South Wales. This project was part of my Masters through the New South Wales Institute of Psychiatry, and I will present the study, its results, and some of the implications for practice. I acknowledge my research supervisors, Professor Nick Swar and Dr. Rosalind Markham, as well as the New South Wales Department of Health, who provided a scholarship that funded my studies. At risk or risky drinking is common in Australia. The beach data demonstrates that around 3 in 10 patients presenting to general practice are at-risk drinkers, that is, consuming alcohol in a manner that places them at increased risk of alcohol-related harm. Many of you will be familiar with the NHMRC alcohol drinking guidelines. Most estimates would suggest that we only identify around a third of at-risk drinkers. What is interesting is that the detection rate does not appear to have changed over time. There are a couple of early Australian studies, Reid and colleagues, and Ryden and colleagues, no more than a third of at-risk drinkers detected. More recently, Berner and colleagues in Germany, again, 1/3 identified in routine practice. Alcohol screening questionnaires have dominated the research agenda of improving detection of at-risk drinking. Most of us are probably familiar with CAGE, first described in 1970. However, it was designed for the detection of alcoholism, that is, more severe alcohol problems. It was also constructed during a major transition period in psychiatry, from psychodynamic thinking to the empirical positivist framework of DSM-3. By the 1980s, the paradigm led by the WHO was for early detection of risky drinking in primary care, the logic being early detection allows for early intervention and lower burden of alcohol-related harm. This led to the development of the Audit, a 10-item screening questionnaire designed specifically to be used in primary care. Later, simplified versions of the Audit, such as the Audit C, have been developed and tested. Most international preventive health GP guidelines suggest the routine use of alcohol screening questionnaires, though the RACGP Red Book is flexible on this. However, my understanding is that very few of us on the ground use these tools. This project was to try to understand this phenomenon. The study had two major aims. First, to describe GP beliefs and attitudes on identifying risky drinkers in clinical practice, and second, to try to understand the low uptake of screening questionnaires. To describe and understand GPs, we need to talk to them. A convenient sample of group GP teaching practices affiliated with either the university or GP Synergy were approached to participate. Focus group interviews were run in the practices, and these were designed to simulate the regular practice clinical meetings. Discussion started with each GP estimating the prevalence of at-risk drinking. A number of trigger questions were used if the points didn't arise naturally. The interviews ended with discussion on the Audit C questionnaire. A copy from the Red Book was handed out to each of the participants. We used grounded theory method as described by Corbin and Strass. This is an empirical qualitative research method that is ontologically pragmatic and constructivist. Some of the key aspects of the method include coding the interview transcripts, initially open coding by going through the data line by line, and then later developing higher level concepts, categories, and themes. Theoretical sampling. Early concepts found in analysis were explored in subsequent focus groups. Constant comparison, new concepts and categories along with new data were compared in the analytic process. Through both induction and deduction, we aim to develop theory in the sense of a hypothesis or potential explanation that is grounded in the empirical data. The analysis was facilitated with NVivo 9 software, and as I'm a fairly visual person, I made use of some of the data visualization tools in the package, such as tree maps in the theory development process. We received ethics approval from both the University of New South Wales and the New South Wales Institute of Psychiatry. Our participants: 10 female and 9 male doctors. There are a mix of GP supervisors, GP registrars, other GPs in the practice, and 1 PGPPP. There were 4 focus groups. All practices were training practices in metropolitan Sydney, and recruitment continued until thematic saturation occurred. The homogeneity of our practices is an important weakness in our study, as it may have led to premature saturation of themes. 4 themes emerged and were constructed from the data. The sequence of these 4 themes reflect the conversational flow of the focus group interviews. GPs initially discussed and identified their role and some of the challenges in detecting risky drinkers. The discussion typically then turned towards some of the reasons why this may have been the case, sociocultural and interactional factors. Lastly, when the doctors were presented with a printed copy of the Audit C questionnaire, they discussed this tool and screening in general. Focusing on just a few beliefs and attitudes, the GPs believed that detecting at-risk drinking was important, but that this was not necessarily as simple as just asking. Many GPs spoke of patients underreporting their drinking. A very strong theme that emerged from the data was the major impact social attitudes toward alcohol use had, even within the consultation setting. Risky alcohol consumption was socially normal, even desirable, but drinking labels were particularly stigmatized. The context of the patient-doctor relationship and reason for presentation seemed important. There were some settings where it seemed difficult to ask about alcohol, at least more than superficially. The GPs perceived a moral aspect to asking about alcohol that was a potential threat to the relationship. The GPs tended to frame alcohol screening questionnaires in terms of practicality and utility. Did they think that it was going to help them in their practice? Almost universally, the GPs felt that routine, universal screening could not be implemented. Intuitively, many GPs felt that the Audit C would over-identify. Bringing it all together, an explanation that could explain our data is that socio-cultural factors appear to have a key influence on the willingness of GPs to attempt to identify risky drinkers. There appear to be 3 interconnected attitudes and beliefs that are barriers. Firstly, there is a stigma attached to problem drinking, and this seems to have an important direct and indirect effects. For instance, the GPs were concerned at being seen as moralizing and were reluctant to label drinking behaviours. Secondly, there were the GP perceptions that patient alcohol use histories are unreliable. This may be due to individuals holding on to the identity of being a normal drinker regardless of their use of alcohol. Lastly, the moral nature of alcohol discussions is a threat to the patient-doctor relationship. GPs indicated that they might opt to preserve the therapeutic alliance by avoiding questions that lead to conflict. It is uncontroversial that there are large cross-cultural variations in social attitudes to alcohol. We can compare, for instance, the difference between the drinking cultures of wet countries like Italy and France to dry or temperance countries like the UK and Australia. The typical depiction of temperance is of her pouring water from one vessel into the wine contained in another. In Australia, alcohol is associated with violence and antisocial behaviour. Drinking places tend to be enclosed and hidden. We propose that these cultural attitudes to alcohol also influence to what occurs within consultations and are in fact the major barrier to the practice of detecting at-risk drinking. This is important as barriers to detection have typically focused on clinician factors. Strategies to improve GP detection of risky drinkers are framed around the correction of perceived clinician deficiencies, for example, alcohol screening education for knowledge and skills, and monetary incentives for time. There is some evidence that these strategies have not been effective, and perhaps our findings offer an explanation. Alcohol screening questionnaires were also perceived to lack practical utility by GPs. In this project, I found it fascinating that the volume of published work on the development and validation of screening questionnaires is enormous. However, the perspectives of GPs who are instructed to use these instruments and of patients who are the recipients of these tools are largely absent. This is a problem. The views of GPs who have experience with alcohol screening questionnaires, for example, those who had participated in research, is typically quite negative. Curiously, our findings were articulated 3 decades ago prior to most of the research on alcohol screening questionnaires. Murphy, a Canadian psychiatrist, wrote in 1980, "Responsibility for the failure of early diagnosis and treatment of alcohol misuse in medical settings lies neither with the patient or physician, but with the relationship of their roles." If we are to move ahead in this field, we need to understand the perspectives of both GPs and patients. We have received funding from the RECGP Foundation for the next part of the project. We will be studying the beliefs and attitudes of patients. Thank you.